Good afternoon. I'm so pleased to welcome everyone to our forum webinar today. My name is Colleen Berry, and I'm the chair of the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, and it's my great pleasure to co-chair the National Academies Forum on Mental Health and Substance Use Disorders with Howard Goldman. This webinar is the third and final installment of the workshop series our forum has been hosting throughout the fall. The topic of the third workshop has been mental health and substance use disorders in the era of COVID, with a special focus on the impact of the pandemic on communities of color. Research has documented rapidly worsening mental health and substance use in the context of the pandemic and its disproportionate impact on health, mental health, and well-being for communities of color. Before we begin today's webinar, let me first thank the sponsors of our forum, who are listed on the slide. Without the support from our sponsors, this work would not be possible. The mission of our forum is to provide a structured environment and a neutral venue to discuss data, policies, practices, and systems of care that affect people with mental health and substance use disorders in the United States. Our statement of task and other information about the forum can be found on our website, which you can see linked here. Please note that a recording of the webinar and the meeting materials will be available on the event webpage. Also, I want to mention that at the end of our formal session presentations today, there'll be questions for our presenters, and those of you attending with questions should enter them into the Q&A box. I'm pleased to now thank our wonderful planning committee for this webinar and to introduce our two planning committee co-chairs, Lark Huang and Deirdre Roche. Lark is the director of the Office of Behavioral Health Equity and the Substance Abuse and Mental Health Services Administration, and Deirdre is the medical project officer with the National Institute on Alcohol Abuse and Alcoholism's Division of Treatment and Recovery Research. And I'm pleased now to hand the baton over to Deirdre to get us started. Deirdre, over to you.
Well, thank you, Colleen. And many thanks again to everyone in our audience for joining us today. The COVID-19 pandemic has created both short-term and long-term negative consequences for behavioral health outcomes. The pandemic has also created, revealed, and exacerbated long-standing racial and ethnic disparities in behavioral health care. The first webinar in this series focused on how COVID-19 has revealed and exacerbated mental health and substance use disorders and highlighted the impact of the pandemic on communities of color. The second webinar focused on access to healthcare and delivery of services for people with mental health and substance use disorders, especially among racial and ethnic groups that have been historically underserved. This third and final webinar will explore the mental health well-being of the healthcare workforce, with a particular focus on the impact of the pandemic on healthcare workers of color. Next slide, please. And now I'm pleased to introduce this afternoon's session, the mental health of the healthcare workforce during COVID-19 and the disproportionate impact on communities of color. Next slide, please. Our distinguished speakers for today's session are Mr. Ted Lutterman, who is Senior Director, Government and Commercial Research, National Association of State Mental Health Program Directors, Research Institute, Dr. Albert Wu, who is professor at the Johns Hopkins Bloomberg School of Public Health, and Dr. Arthur Evans, who is Chief Executive Officer and Executive Vice President for the American Psychological Association. In the interest of time, we refer you to the full bios for our speakers in the program planning book. Next slide, please. Please join me in welcoming first Dr. Ted Lutterman.
Thank you very much. I appreciate your inviting me to present today. Let me start. I have no conflicts to report, and I am with the National Association of State Mental Health Program Directors, the Research Institute, which serves as the research data arm working with mental health agencies across the country. The study I'm talking about today was funded directly by state mental health agencies that wanted to understand how the public mental health systems were being impacted by the COVID pandemic and to share lessons learned with each other. I want to thank the states for taking their time to respond to our survey and follow up questions while they were in the midst of dealing with this pandemic. Next slide, please. For people that are not familiar with what state mental health agencies are, there is a state mental health agency in every state designated by the governor as the state's lead agency responsible for the organization and provision of mental health services. In 40 states now, this mental health agency is combined and does both mental health and substance abuse services, often called a behavioral health agency. And the states are responsible for serving over 8 million unique individuals each year. Over 2.2% of the adults in the US, 3% of children get served by the state system. And every state operates psychiatric inpatient services, but that's where a minority of clients go. About 2% of clients go through state hospitals during the year, but it's a very intensive, expensive service that costs over $11 billion a year. The majority of people, though, receive services in community mental health providers, often private not-for-profits that the state works with. And the state's also responsible for monitoring the quality of services, planning for services, setting standards, and often licensing mental health providers, and then working with Medicaid and other agencies to finance services. Next slide, please. I want to point out that the state mental health systems disproportionately serve people disadvantaged economically and persons of color. Persons of color, particularly Black, African Americans, Native American Indians, Native Hawaiians, and people with more than one race are all served at much higher rates than white clients when we look at them in population adjusted terms. 69% of our clients served by the public system had Medicaid pay for some or all of their care. And that comes back to mostly the state mental health system are serving people without any insurance or with Medicaid private insurance because they do not have jobs that bring private insurance. And we see that in the data that only 21.7% last year of all adult mental health consumers were competitively employed during the year. And with people, for example, like a diagnosis of schizophrenia, only 9.2% were competitively employed. So most of the people served by the public system are economically disadvantaged, people of color, 6% were homeless, and almost 28% had a co-occurring mental health and substance use disorder that required treatment for both. Next slide, please. So we periodically do a study that tries to gather information about how each of the state mental health agencies is organized, structured, their major policies and services. And we had just started that when the COVID pandemic started hitting states. And we were hearing from states wanting to know what other states were doing, what are some lessons learned, how do we not reinvent the wheel? And so we brought together a group of senior mental health commissioners to discuss this, and they identified areas that they thought would be helpful for us to do a survey. So we drafted a survey, piloted it with several states, and then sent out to states in June. And by the end of September, we had responses from 41 states, and that's what I'll be presenting on today. I do want to caution, though, that that means that this report was completed before the current pandemic wave that's now hitting some states that back when they first responded hadn't been hit nearly as bad. Next slide, please. So the states wanted us to focus on what's the impact on state psychiatric hospitals and the staff in them, the impact on community mental health systems, and again, the thousands and thousands of staff that work in those, the impact on crisis services, the impact on children and school-based services, since so many children are out of school and can't receive school-based mental health services, the use of telehealth, and also we were focusing a number of issues around how states were obtaining necessary personally protective equipment in responding to the COVID epidemic. Next slide. So what we heard in state hospitals, for example, is that it's been a major stressor on state hospitals. Over half the states have decreased the capacity of their state hospitals to provide services to people needing critical inpatient services. They reported the need to limit admissions to the hospital. They decreased capacity due to the need for social distancing. So they often needed to shift people to one client per room, or various other reasons. In essence, we ended up with 15 states that reported over 1,666 beds closed from March through the summer. That's an average of 12% of their state hospital beds were closed. But I also want to point out that a few states indicated they actually had some increased demand for care at their state hospital. And what they were seeing was general hospitals in their state were closing their psychiatric units down, at least temporarily, to focus on patients with COVID. And then the question was, where do those people need to go in order to get services? We had many states reporting they experienced a workforce shortage due to COVID, that staff were getting sick or getting potentially infected and needed to quarantine or isolate. And we had major issues early in the pandemic with obtaining adequate supplies of personally protective equipment. And some states had to ration or even reuse PPEs. Now they're reporting currently that states have sufficient PPEs, but it's still costing much more money and diverting staff time to continually be updating supplies of PPE. Next slide, please. So some examples of what we heard from states in explaining the necessity of social distancing. It required shifting patients to one patient per room, new isolation or observation rooms. Some states even opened negative pressure rooms for people with mental illness needing psychiatric inpatient care, but who were also COVID positive. And all of this put a new stress on psychiatric hospital staff who weren't used to dealing with this kind of an intensive infectious disease. They're used to and working with people with psychiatric illnesses, but not this additional stress of dealing with COVID risks and infections. And a number of states also listed staffing shortages due to the staff themselves becoming infected or exposed to COVID, causing a decreased capacity and again, increased pressure on the staff. So specifically, next slide, on workforce impacts, many states reported that COVID has greatly stressed their workforce and is leading to increased costs of providing care. They've had issues such as staff needing to self-quarantine after COVID exposure. That's led to staffing shortages. States talked about having to do mandatory overtime, bring in outside temporary staffing when they can find it. Several states have brought back retirees or moved administrative personnel back into direct patient care. And they also reported that other stresses on their workforce included many needing to stay home to care for family members, especially staff with children who are at home due to school and preschool closures. So the end result was we had many states reporting their workforce is very stressed, and those working are covering for absent staff and sort of getting by. The overall cost of providing inpatient care is thus increased. Next slide. Similarly, in the summer, 36 of 41 states were experiencing a reduction in face-to-face community mental health services. We think today that might be even higher given the resurgence of COVID. And much of this reduction were in group services, group therapies, as opposed to individual therapy that could be replaced by telehealth. But many states also experienced decreases in some group therapy services that are evidence-based practices, such as assertive community treatment or coordinated specialty care for people with first episode psychosis. And the issue there was many of those services are actually provided in a client's home, at school, or a workplace setting, and thus were curtailed due to concerns about potential COVID infection. 30 of the 41 responding states reported that community providers had reduced staff and services due to COVID. The number of states talked about having to furlough staff for a while. And Dr. Joe Parks from the National Council detailed this during his session in the workshop held 2 weeks ago. So I encourage you to look at his slides if you're interested in that issue further. We did hear there was a great use of telehealth in community services to replace many of the face-to-face services, but this shift has still left some providers challenged because it may not bring in the same revenue as they were doing face-to-face services and having to curtail doing group therapy services. Next slide. Another big area was congregate housing, trying to have places for people to live in the community, keep them out of hospitals. And 16 states reported they've had to reduce the use of congregate living situations such as group homes due to concerns of COVID exposure. We had several states providing examples where people in a group home or a residential living situation had experienced COVID, and they had to close the entire 8, 10, 12 bed facility to clean and work on it, and the issues with the staff also. So that just becomes an issue that we've felt reverberate through the system. If there aren't places in the community for people to be moved to when they don't need more intensive inpatient level care, the question is, where do they go? And so we had some states saying that people were backing up in hospitals, increasing lengths of stay, and reducing the ability to take new admissions because they didn't have a safe place in the community to discharge somebody to. The next slide. We also heard about an impact on crisis systems. Over 3/4 of the states implemented new hotlines or warm line systems in response to COVID. A number of them were designed for first responders and also for the general public who had anxiety and concerns due to COVID. And we've had a large increase in calls to suicide and crisis hotlines experienced by states. At the same time, we had states reporting, at least temporarily, a decrease in some of the face-to-face crisis services. The peer-operated respite was shut down due to the staff being medically at risk, and they didn't have enough PPE, for example. The crisis residential services decreased in one state by 15%. Crisis diversion residential programs were closed for a while because the crisis residential program had an exposure to COVID. And so all of this impacts the services for people with mental illness, but also our workforce that was running these programs. Next slide. We did hear that the declaration of the federal public health emergency that eased a number of the flexibility, provided more flexibility to use telehealth, was very helpful to states. That states have really replaced a lot of face-to-face potential exposure with telehealth. And so there's been a large increase by community providers, but it's been hard for states to actually come up with measures of the volume yet. So that's something we need to look at in the future. A number of states had to provide funding to community providers to have the necessary equipment to provide telehealth. We even have some states working on practice standards to assure behavioral health is high quality. And if we go to the next slide, in particular, states reported that the ability to use audio only, voice only telehealth has been very helpful, particularly in rural frontier states where broadband internet may not be widely available. And they also said it was helpful for economically disadvantaged clients who may not have a smartphone, and for elderly who could use the voice only telehealth. So we ask states both, has the change in the rules been helpful, and which should be continued after COVID, the public health emergency expires. And we see in this chart that the expansion of services that could be delivered by telehealth, audio only, changing where telehealth can be provided, types of professionals that can do telehealth, all of those have been found very helpful by the mental health systems across the country. Next slide, please. We also heard that states said that the use of telehealth has greatly reduced no-shows at community mental health centers during the pandemic, that appointments have been increased significantly in one state, number of appointments kept, especially in rural impoverished areas, because people didn't have to travel a long distance to get to the service. The transportation issues are somewhat resolved by telehealth. So there were some real positives there, but there are also a few concerns that states have been raising about, for example, an audio only telehealth does that work well for a new client just coming into the system? Some of the therapists were saying they really want to see the person to know what's going on. And we'll come back in a bit that there's also concerns about privacy in some settings. The next slide, please. In terms of the behavioral health workforce, a number of states, in order to get adequate workforce in the behavioral health system, had to change their licensing rules or regulations during the pandemic. So we've seen states expanding rules to allow more advanced practice nurses and physicians assistants to be involved in care. States that talked about emergency licensing procedures for nurses were enacted, allowing nurses from other states to practice without an in-state license. Some states were waiving continuing education requirements, allowing nurses with expired licenses of less than 5 years to practice. What we heard was states were bringing back some people that had retired or staff that may have moved into management and administrative roles and allowed their clinical license to expire to quickly bring them back in to fill in as staff are out. The next slide, please. And we also heard in terms of children's mental health with kids out of school and missing school-based mental health therapy that there was an issue. And a number of states have been working with their local boards of education, with their school boards, and it's been a new role for some of their children's mental health service providers to try and fill in and do telehealth or reach out to kids while they're out of school. And similarly, most of the states described activities to try and help kids in foster care doing services remotely. But that also did raise several concerns that states had. That is a child in a group home or in a foster care, if you're doing telehealth, is there true privacy and confidentiality that's available? And there was also a concern by a state that children in very rural or remote areas may lack access to reliable internet, making telehealth unrealistic. So again, the workforce is still struggling with how to exactly do we serve children and do telehealth with children in some settings. The next slide, please. So in sort of to wrap up, what we heard was that the state mental health workforce in both state hospitals and community providers is being very stressed by COVID. There's a result in reduced face-to-face services, but there are also frequent absences, increased overtime, and temporary replacement staffing has been needed. Some community providers have closed, although it's mostly temporary closures. There have been some that have been permanent, and that puts additional stress on the workforce. We're hearing the cost of providing services is increased by the need for all the precautions around COVID exposure, getting PPE, the time it takes to use that. And very scary is the future budget shortfalls that many states are facing because of the economic slowdown, because of the COVID's impact on the economy. So the full report is available on our website if people are interested. I do want to caution again, though, that the results that have been talking about were all gathered over the summer and don't fully reflect the current wave that's now impacted additional states. And again, I think one of the concerns we're hearing from states is telehealth is being widely used by the workforce, but we still have some questions about how well does audio telehealth work, and concerns about children or even adults who are in group homes or foster care settings. Can they have the privacy that they need to do all the services? So with that, thank you very much and look forward to the next speakers.
So thank you very much. I'm privileged to be addressing you today, and I think that the topic could not be more timely. So thanks to our moderator, Dr. Berry, and also to all of the committee members and other speakers. So I am going to talk much more specifically about the impact of the pandemic on the mental health of healthcare workers. And most of my data come from workers in hospital. Next, please. These are data from just last week, and I think that I will spend relatively little time on this. There were, on December 10th, there were over 200,000 new cases and 3,000 deaths. In the last 10 months, over 15 million cases have been reported, with over 200,000 new infections a day for many weeks. Currently, over 100,000 people are hospitalized, with over 3,000 deaths a day. And ominously, intensive care beds are critically short for a third of the US population. Next, please. There's been significant disparities in who gets infected. Looking at cases per 100,000 of population, Native Hawaiians and American Indians, Hispanics, and Black and African Americans have all been infected at a disproportionate rate, and deaths have been particularly disproportionate, particularly for American Indians, Latinx people, and Blacks. Next, please. The data are not precise for US healthcare workers. The CDC reports that more than 260,000 health workers have contracted COVID-19 and 892 have died. But they already admit that death status is only available for 75% of those for whom they have any data. There have been criticisms that there's been a failure by many to effectively track and report the number of deaths, and a project sponsored by Kaiser Health News and The Guardian reports that at least 1,445 workers have died after contracting COVID on the job. Workers of color are more frequently exposed to COVID patients, are more likely to lack sufficient PPE, work in high-risk settings like nursing homes, live outside of the hospital in densely populated communities or residents, all of which increase their risks of infection. Next, please. Most of those deaths from the Kaiser and Guardian data have been nurses, which is not so surprising. Coming second are other support staff, with physicians coming a distant third. Next, please. The pandemic and working in healthcare settings has had a significant negative impact on the emotional well-being of health workers. And dating back to March, when everything was unknown, in the short term, there was a great deal of fear and anxiety for one's own health and for family, for role changes, being furloughed or being commissioned to work elsewhere. There was a lot of anger and frustration, and also anguish and grief at the unprecedented numbers of death, and also seeing people dying alone. In the longer term, there is increased risk for burnout, and as we've heard, worsening of mental health conditions, and for PTSD. Next, please. A large meta-analysis published in the Journal of Occupational Health looked at the impact of the COVID on the mental health. And this should be the mental health of hospital workers, and the prevalence of depression, anxiety, acute stress reactions, PTSD, insomnia, and work burnout ranged up to 40%. Risk factors for greater prevalence of these problems included direct exposure to patients, working as a nurse or otherwise on the front line, having poor social support, and having less work experience, being younger and having been on the job for a shorter amount of time, perhaps having had less time to expose to all of the real tragedy that has accompanied the pandemic. Next, please. right now, I would say that things are worse. And this is perhaps not surprising. After the initial impact of the pandemic and a subsequent heroic phase, we have since March collectively slid into a long and deep period of disillusionment. This is a plot actually developed by Zunin and Myers with data dating back for the last 40 years for disasters of all kinds. And it turns out that disasters elicit more or less predictable psychological patterns. Where we are now is after the adrenaline has worn off, after original altruism and optimism and frenzied behavior has calmed down, the reality has set in. Resources are now more limited, and people are beginning to feel abandoned. Next, please. A quote which we heard from some of our workers just a couple of weeks ago is, "We don't feel like heroes anymore." And in the last month, perhaps, both at our institution and across the country, there have been reports of numerous sick calls and call-outs, multiple people taking leaves of absence or even early retirement, more incivility, blaming one another, anger, anxiety, emotional outbursts, people verbalizing fatigue and despair, and even problems with performance, which may not be surprising as people are working short-handed, longer shifts, doing doubles, many people not having taken a day off for weeks or even months. Next, please. How are you coping? Someone last week that we spoke to said, "I'm not coping, I'm just surviving." And this meme stolen off the internet is a picture of someone standing in front of a candy machine. The candy machine has a note on it which says, "The light inside has broken, but I still work." And a comment is, "A better definition of burnout I have yet to read." And many people are working and walking wounded, and this is an incredibly prevalent situation in our hospitals today. Next, please. So attempts have been made to provide support both to workers and the general population outside of hospitals, but also inside hospitals and inside of healthcare. And some of those policies, most of those policies have been quote unquote colorblind. And the question you might ask is whether or not this is a good thing. The term originally referred to race-neutral government policies that really aim to reject discrimination of any kind so as to promote the goal of racial equality. In more recent years, though, the term has been understood and has been taken to refer to when legislators don't consider pre-existing disparities, there is a risk that those disparities may be worsened. In general, many policies don't wind up working for everyone, and it's primarily white Americans who are able to benefit from them. An example might be rental assistance programs for COVID-19, which were race blind. But not surprisingly, the very large majority of rental assistance funds went to those who signed up quickly, and virtually all of those were white Americans. When mass transit was cut off in Baltimore early in the pandemic for reasons of not wanting to infect people riding mass transit, that seemed very reasonable. However, the workers at Johns Hopkins Hospital who were affected most were those workers who used mass transit to commute to work. When this was cut off, they were forced to use private vehicles, and now they needed to pay for parking. And these were people who were least able really to pay extra in their budgets to get to work. Next, please. So even in developing support systems, and I think all systems, and particularly the strongest systems, have worked hard to try to support their workers. I think that at first approximation, all health systems understand that workers are the greatest asset that any organization has, particularly healthcare organizations. The picture here, by the way, is from the Kaiser Health News and Guardian website. All of these are workers who have died, known to have died of COVID. And as you can see, the majority are people of color. There are challenges to reaching and helping people, even in the hospital, where they might be relatively close at hand. The way a support system, a support asset is described may make it sound like, well, this isn't for me. Health literacy varies, and many workers of color have lower health literacy and lower understanding of the messages that are coming to them, even messages that might say this is the best way to protect yourself from catching COVID. The channels that are used may not be uniformly used by all workers. Interestingly, while virtually everyone these days has email one way or the other, nurses in the hospital, particularly those who are the busiest, often don't use email because they're working day and night and don't really have time to check their email. This applies even more to those who do not have ready, reliable internet access, non-professional staff who are not nurses, doctors, pharmacists, or techs, but who work elsewhere in the hospital, in housekeeping, in food service, in environmental service, in security, laundry, and other. Language is obviously potentially a barrier, and trust. If someone says, I have something here to help you, do you trust the person who's offering you that help? And culturally, many have resistance to asking for help. In healthcare, as many of you know, people are generally pretty tough. They tend to think of it as it's the patient who has the problem, and it's not really done. You don't ask for help. It's undesirable to show that you may be so weak as to need assistance. Next, please. Johns Hopkins Medicine, fairly early on in March, realized that although we had many helping services, they were not coordinated. They were siloed, as almost everything is in our system. I'm going to use this as a little bit of an example of some of the things that we did, but some of the things that we also failed to do. This is a picture of workers from human relations, from the wellness program, from our employee assistance program, from psychiatry, from chaplaincy, and also from a program that we have that we call RISE, or a peer support program. We developed a series of supports which attempted to support people at every level, shown here on Maslow's hierarchy. Certainly people need physiologic needs met, needs for safety, particularly important in the pandemic, but then psychological needs of basic support, contact, and then self-fulfillment, self-actualization. People need to feel like they're making a difference to keep going to work every day. Next, please. RISE is a program which stands for Resilience in Stressful Events. It is a voluntary peer support program. When we started in March, this program has been actually around since 2011, but when the pandemic started in March, we had about 35 volunteers, a very multidisciplinary group of nurses, social workers, doctors, psychologists, and then pharmacists, EMTs, and many others. The service is entirely confidential, and those workers are on call. Someone is on call 24/7 to provide support to anyone who is so stressed that they need to call and talk to someone. The mission is to provide timely peer support to workers of all kinds who encounter stressful events at work. During the pandemic, RISE began to do virtual encounters, whereas previously they'd all been face-to-face, though we still suited up and at times worked in the COVID units in person to provide support with individuals and groups. And we began to round proactively on units, particularly the busiest units. Additional people were trained, and there was a great increase in the number of people supported, whereas previously we might have helped a few dozen people on a given week. Between March and December, over 3,000 staff called and were supported by the RISE program. Next, please. But even so, and using RISE as an example, there are challenges. We early on realized that we were not getting calls from many places and many people who we had evidence were highly stressed, people who were transporting patients from one place to place, including those who had COVID. Security workers, people working in environmental services and cleaners, as well as laundry workers who were coming in contact with infected patient material. These individuals were not calling, and we began to wander into places in the hospital that we mostly, our workers mostly did not venture to, in order to figure out what the problem was. The security workers who we talked to explained to us that they saw that this program existed, but they didn't think it was for them. They were actually contracted. They were outside contractors, and they didn't figure they were really Hopkins employees, and they didn't figure that they were entitled to the support. We encountered, particularly in our basement, in our sub-basement, some of our workers had limited health literacy, and for that matter, limited literacy. And even though there were announcements and there were emails, and ultimately there were announcements on the plasma screens in the hospital, there were individuals who could not read or see themselves in the descriptions that were given. Some people did not have smartphones, did not have regular internet access, and even though there were all sorts of communications going out all of the time, they did not see that, didn't see them and didn't realize that they were available to them. Some of those people spoke Spanish as their first language. Some did not trust that the people who they spoke to would keep what they had to say confidential. And again, as I mentioned, some people just didn't feel like it was something that it was done, that they did not routinely ask for help. We've attempted a number of solutions. One was to greatly broaden our marketing. We started to broadcast on all of the screens in the hospital, including the plasma screens that don't require individual workstations or phones. We began to distribute little postcards which had a brief message and information about numbers to call or places to go. We began to send out messages in Spanish, and fortunately we do have Spanish speakers for many of our support teams. Rather than waiting for people to come to us, we began rounding, and in fact for some time now we've been rounding with what essentially looks like a goodie cart, which is brightly colored and is attractive because who doesn't like goodies of various kinds. Some people approached us sometimes and said, could I Venmo you to get some of those goodies? And we said, oh no, they're free. And then some of those people would talk. We enlisted the help of supervisors. We discovered that some of those supervisors, not a secret, but a secret perhaps to us, were very influential with their workers. We found, for example, a woman who seems to be the mother of all environmental services workers, and people always go to her for advice. And we gave her a lot of our material to encourage her workers to come and talk to us. There is a resource group for Latinx people. We began to do more community outreach outside of the hospital. There's a vaccine equity group, and we now also have a chief diversity officer who are looking out to make sure that when we make a change, when we have a policy, when we institute a program, that it will reach, hopefully, all of the groups in the hospital. Next, please. A lot of the problem that organizations have is with leadership. George Bernard Shaw said the single biggest problem in communication is the illusion that it has taken place. And many managers and leaders feel like they're doing just a great job in communicating with their workers. Their workers might disagree. We have developed a program for frontline crisis leadership training. And the goal is to enhance the well-being of workers by strengthening crisis leadership and communication. We've been doing this now for almost 4 months, and over 1,000 managers and top leaders at our 6 hospitals locally have been trained. Those videos, some of the training videos can actually be accessed here and in my references, and you'll be able to find them when all of this goes online in a couple of days. Next, please. I won't go into this in great detail, but we try to impart 10 principles of crisis leadership, which is a little bit different than leadership in general. When people are scared and panicked and adrenaline is pumping, they don't listen to you as carefully. They're likely to be more skeptical. They're likely to be less likely to follow what you say or even believe what you say. And so some of the principles that we are espousing and trying to convince people to use more frequently may seem obvious, but are not always practiced. One is listen before you speak. And we encourage all of our leaders and managers to listen and really acknowledge before telling their workers the things that they all should do. There's still a great deal of anxiety, and information is changing all of the time. Information is the antidote to anxiety, though, and giving people information empowers them. People do trust action and not words. If you are speaking about masking and not wearing a mask, people aren't going to trust you. An important point is there's no such thing as an information vacuum. Healthcare managers and leaders are competing at all times against the vast rumor mill and all of the misinformation that is circulating, not with malign intent, but is circulating all the time, particularly about COVID. Transparent and timely and truthful communication is essential. And even when things are not going well, that should be communicated. When you don't have the solution yet, you should say, we don't have a solution yet, but we've heard you, we're working on it. Next, please. So in summary, COVID-19 has been the defining crisis, health crisis of our generation, and it has had a disproportionate impact on health workers of color. There are challenges that need to be thought about, that need to be considered actively when developing programs if you would like to avoid exacerbating disparities. Comprehensive institutional solutions, however, are needed. I would simply repeat that achieving equity requires conscious effort at all times. Next, please. Next, please. It's possible that there's light at the end of the tunnel. Maya Angelou said, every storm runs out of rain. I think the trick will be to get to that light at the end of the tunnel rather than being trapped there, which is honestly where we are at the moment. Next, please. Here are a number of references which will be provided to you at a later time. Next, please. And I'm always happy to answer questions on email. And if you're dying to follow one more person on Twitter, I'm with you, Dr. Wu. Thank you.
Okay, hello. Arthur Evans from the American Psychological Association, and my two previous presenters, colleagues, did a nice job, I think, of setting up this last presentation, and in particular, Dr. Wu's comments about some of the unique challenges in addressing the mental health needs of communities of color. So what I want to do is a couple of things. One is I want to talk about the issue of how the pandemic is having an impact on healthcare workers who are from communities of color, from a mental health and a substance use standpoint, and what we can do about that. My primary goal is to help folks understand some of the unique issues that people are experiencing, and then leave you with some ideas and principles that ought to be in front of mind as you're thinking about how to approach this. So next slide. So the first thing is to recognize what the environment is that in which we find ourselves. We not only know that the pandemic is creating a tremendous amount of psychological distress and stress for the population, but we also have an economic downturn which disproportionately affects communities of color. We have the concerns around racial justice in the aftermath of George Floyd's death. We have the stress related to the election and all of the things that have come out of that. And we have documented how all of these things are contributing to the stress of the nation. Next slide. So let me start to dive down a little bit on what that looks like. One of the things that we know is that different groups of people are experiencing the pandemic in different ways. We know, for example, that parents are experiencing more stress than non-parents. We know that women are experiencing more stress than men. We know that, excuse me, communities of color are experiencing more stress than other communities. And so we know, number one, that there are these differences within the population. And we know that the younger population, the younger adult, particularly between the ages of 18 and 29, are experiencing significant amounts of stress and symptomatology. In addition to that, we're not only documenting the levels of stress in the nation through our Stress in America survey and other surveys, but we're also seeing increased symptomatology, somewhere between 3 to 6 times the level of symptomatology that we saw before the pandemic. So we know that people are not only stressed, but it's showing up in terms of symptoms of psychological distress, disturbances in eating, disturbances in sleeping, and so forth. Next slide. When it comes to healthcare workers, they have additional stress on top of the stresses that we're seeing in the general population. Next slide. Dr. Wu talked about some of the, I'm sorry, I went on mute for some reason. What we're seeing is that that healthcare workers are facing additional stressors, concerns about contracting COVID themselves, job burnout, which was something that was an issue prior to the pandemic and has only been exacerbated because of the pandemic. The lack of adequate PPE and other equipment, repeated exposure to people who are experiencing and suffering from COVID, the isolation from their own families as they try to protect their loved ones, direct and vicarious trauma, feelings of responsibility and guilt, the stigma associated with being someone who is at high risk if you're a healthcare worker, and the moral injury. So all of these things add on to the stresses that we're seeing in the general population are additive for many of the healthcare workers and people who find themselves in these roles. Next slide. All of that is having significant consequences. And we know just from the literature and from research is that when you have this level of psychological distress and stress, within a population, that will lead to depression, anxiety, suicide, and we're already starting to see signs of that, and including the kind of burnout that you heard Dr. Wu talking about. Next slide. So I don't want to paint a completely bleak picture, because there are things that we can do to address this. I think it's important for us to be more proactive than reactive. I think one of the challenges that we have just generally in how we deal with mental health issues and substance use issues is we tend to have a very reactive approach. But there are things that we can do on the front end that can mitigate the level of stress and distress that people are experiencing, and thereby reduce the likelihood that people are going to develop more deep-end issues. So one of them is to be intentional about building resilience. And one of the ways that we can do this is just simply acknowledging the level of stress that people are experiencing, and making sure that people have the resources to deal with that. It's also important to identify signs of traumatic stress. Every person within the healthcare environment should have some basic understanding of when people are experiencing stress and distress, and have an idea about how to deal with that. It's one of the reasons that in my previous role as a mental health commissioner, we spent a good bit of time training people on mental health first aid, so that we had a group of people in our population who could help to identify when people were in distress and know what to do about that. So it's something that that organizations can think about as we come out of this pandemic. But in the meantime, being able to recognize those stressors, and then making sure that people get connected to resources early. Infusing mental health into how the organization works, making sure that it is a legitimate issue and of concern, and that there are policies to make sure that people have access to the services that they need, and then also providing forums for being able to talk about these issues, and forums that create a sense of psychological safety. Next slide. So we know that the general population has a certain level of stress and distress. We know that healthcare workers have additive stress and distress related to unique issues that they are facing. And communities of color also have yet additional stressors that they're facing that other communities don't. Next slide. So after the death of George Floyd, our association talked a lot about the impact of racism on people's health, and both their health and their physical health and mental health. And our president, Dr. Sandy Shulman, issued a statement in which he talked about and described racism as a pandemic itself, and that it operated like the pandemic and like the virus. And she described racism as being associated with a host of psychological consequences, including depression, anxiety, and other serious and sometimes debilitating conditions, including post-traumatic stress disorder and substance use disorder. And that moreover, that the stress caused by racism can contribute to the development of cardiovascular and other physical diseases, as well as mental health issues. Next slide. We see that within communities of color, are experiencing unique stressors. So for example, in our Stress in America survey, we saw not only that concern about violence by police against communities of color was a significant area of stress, but we saw that stress level has grown over the years. So in 2016, 36% of people said that was a significant source of stress, whereas in 2020, that number has gone up to 60%. Similarly, among people of color, about 44% report discrimination as a significant source of stress. And in our most recent survey, which is up compared to 38% of people who said the same thing just last year. So we know that there are both these unique stressors and we're seeing an increase in how people are experiencing those stressors and what people are reporting. Next slide. Around the pandemic itself, what we're seeing is that the disproportionate impact of the pandemic is contributing in large part to the increased stressors that African Americans and Latinx and other communities are experiencing. So for example, the fact that communities of color are more likely to contract COVID, that they're more likely to become seriously ill, and that they are more likely to have challenges in getting testing and getting treatment are all contributing to the level of stress that people are experiencing. Next slide. In addition to that, communities of color are also more likely to be employed in service industries where they are going to experience greater exposure to the virus and increase their likelihood that they might contract COVID. In addition to that, there are some unique things. A recent article talked about concerns from African American men who were concerned about wearing masks because they were afraid that that would increase the level of profiling that they might experience as African American men and police harassment because they were wearing a mask. This was particularly true in the front part of the pandemic. So there are these unique things that communities are experiencing that other communities are not experiencing. Next slide. And then finally, we all know that if you are from a community of color, that you are much more likely to die because of COVID than other groups, particularly for African American, Indigenous, Native Americans, and then also for Latinx individuals. Next slide. So people who have looked at these issues, these stressors that communities of color face, have summarized that literature and talk about some of the implications of all of that. Heightened vigilance, race-based traumatic stress, decreased resilience. That's the ability to bounce back from the kinds of stressors that people are experiencing. Increased depression and anxiety and increased psychiatric disorders are just some of the ways that all of this plays out on communities of color. Next slide. Again, I don't want to paint a purely bleak picture because there are things that we can do and there are things that we know that can help communities of color respond to these stressors and this level of distress that they're experiencing. We know that faith and spirituality is generally, across all populations, is both a protective factor and a source of support and strength for many individuals. We know that faith communities can often encourage people to find meaning and purpose in what is happening to them, which gives people some solace and comfort. We know that social support is another very important factor in terms of helping people address the stressors that they are experiencing. A lot of research that shows that social support is directly related to people's level of physical health and psychological health. And so the more that we can help people both develop and rely on their social support, the more likely it is that people are going to experience better psychological health. And we also know that positive racial and ethnic identity is very important in terms of people's coping and ability to bounce back and to be resilient. Next slide. So talk a little bit about workers, people of color who are healthcare workers. Next slide. In terms of some unique issues. And one of the things that happens for communities of color is that they do face these unique issues. So for example, a physician who reports that he wears his scrubs everywhere he goes because he knows that if he's wearing his scrubs and he looks like a doctor, that he's going to be less likely to experience some forms of discrimination that he would experience otherwise. So that's something that's really common for many people of color, that they will be very conscious about what they're wearing and so forth, because depending on what they're wearing, it can have a big impact on how they're treated, in whether it's in a store or in a healthcare setting. Next slide. So let me talk a little bit about how we can use all of this information to shape how we begin thinking about how we help address some of these issues. And I first want to talk about research, but I'll talk a little bit about policy and practice. Next slide. So if you look at the issues that drive the disparities, some of the disparities that we've talked about, there are individual level factors like interpersonal discrimination. There are organizational factors, and we've heard a lot in the aftermath of George Floyd and some of the other more significant or visible events that have happened around racial justice lately. More conversation about organizational racism or institutional racism. The fact is that the way organizations operate can sometimes discriminate against people, not necessarily intentionally, but because of long-standing ways that they have operated. So that's another set of issues that can contribute to discrimination. And then there are the broad societal or systems issues, issues like housing policy, where people live, educational policy, these broader social policies. And if you look at these factors, the things that have the greatest impact are these broad societal policies, whether people have jobs and where people live and so forth. Organizational have somewhat less of an impact. And then the individual issues, even though they can be quite traumatic for individuals, if you look at communities of color as a whole, they tend to have the least amount of impact when you look at those issues in relation to some of the other organizational and systems issues. Next slide. But if you look at the literature around how do you address some of these issues, the literature is actually inverted, that we spend most of our resources in terms of research looking at individual level issues, relatively less on organizational, and then even less on some of the systemic issues that drive some of these disparities that we see in terms of people of color's mental health issues. So the point of this is that as we think about our research agenda, we really need to be looking at some of the larger issues that are affecting people's mental health status, their levels of psychological distress. Next slide. And so that we are better aligning our research and the emphasis in the research on the things that are having the greatest impact on people's mental health status. Next slide. So as we think about how we intervene, there are three levels that we ought to be thinking about, both the individual level, those kinds of interpersonal issues that I was talking about, the organizational level, and then the broader systems level. And because we're talking about healthcare workers, I'm going to focus in on some of the kinds of things that organizations can be doing to help address the unique stressors that communities of color are facing. Number one is to recognize that there are differences within populations within the healthcare workforce. Very important. Dr. Wu mentioned that and the lens that I look at that is that what we're looking for is equity. So if the goal is to help everyone have good psychological health, then the reality is that we have to do different things for different individuals, that there is no one size fits all. And for organizations that want to be impactful, it's important to understand that having different strategies for different groups is a way that you get to that environment where everyone in the environment is healthy. Very specifically around this issue of how do we deal with this issue relative to communities of color, some suggestions would be that it's important to legitimize this issue uniquely for this community. So a general statement about the importance of mental health may not reach the people that you are trying to reach. And so if you want to do that, how do you craft a message that is more directly related to that group and will be more likely to be received by those groups? Using key informants or people who are have that informal influence with their communities is another strategy around reaching that community. And then one of the strategies that I deployed quite a bit when I was a mental health commissioner is what I call going through the side door. And what I mean by that is that to talk about and address mental health issues, we don't always have to go through the front door talking about mental health issues. Sometimes you can come through the side door. So for example, one of the strategies that I've employed is using storytelling events or other kinds of community events in which the themes that were being discussed had to do with mental health issues, and then having a discussion afterwards about those issues. So all of those are strategies that can be done at the organizational level that can help address these issues. Next slide. Some other recommendations, specific recommendations, normalizing conversations about psychological health, which I've mentioned, create multiple pathways that no one pathway works. So having employee assistance programs, having support groups, having individual information available to people, all of those things are different strategies, and recognizing that those different strategies can be really important because different people will respond better to certain strategies. Acknowledging the unique challenges that healthcare workers from communities of color face, and then also recognizing that within the healthcare community and communities of color that there is diversity. So the issues that a physician who is African-American man or might be dealing with might be very different than the issues of a person from the same ethnic group, but who's working at a different level within the organization. And so different strategies are often needed. Next slide. There's a program called Black Emotional and Mental Health, which is a great example of what I've just talked about, but it uses multiple strategies to reach people in terms of their emotional and mental health. Next slide. So I'm going to end with just a couple of other considerations. One of the things that I think it's important for people to recognize, particularly for all communities of color, but particularly for the professional staff, that every day that they walk into their building, they are putting on different forms of PPE. Some of it is to protect them from the physical issues related to the virus, but some of it is psychological. It is like the physician who wears his scrubs everywhere to prevent forms of discrimination from happening to them. Well, that phenomena is always present for communities of color. And one of the things to recognize is that is something that is unique, that communities of color are doing all of the time. There is a cost to that, and that is yet another source of stress, but also something that people should be aware of as they're thinking about how to intervene. And secondly, next slide, that the way these issues play out for different for people are different. We know that traumatic stress, for example, can lead to PTSD. We know that, but it can also lead to depression. It can lead to anxiety. It can lead to substance use disorders. It can lead to a lot of different things. And so the way these things manifest themselves is different for different communities. And therefore, you have to have a broad set of strategies to recognize when these issues are happening and then to be able to intervene. And next slide. And last point I'll make is this. The issues that communities of color are facing now are significant, but many of these issues are things that pre-existed the pandemic, and that whatever the strategies are that are being employed now, it should be with an eye that these are long-term strategies that will help address these issues long-term. And so with that, I'm going to end my presentation. I look forward to questions and hearing what comments people might have.
Thanks, Dr. Evans, and thanks to all our speakers. Wait just a second while the applause dies down before we handle the questions. I've been able to field a few questions from the audience and tried to mash them together. We really only have about 10 minutes for questions, so I'm going to try to be circumspect. There were a couple of factual questions that people wanted to know, Ted Letterman, whether NASHBID plans to repeat the survey. And for all of you, if any of you know of similar surveys done in the private behavioral health care system.
We are discussing with our steering committee whether it's worth the time and effort to repeat the survey, and if so, when the right time to do that is. Right now, we have a number of states that are really in the midst of dealing with COVID at their hospitals and stuff. So, you know, we'll be probably deciding in January if we want to redo the survey then. We're also looking at questions about what's going to be the role of the public mental health system in doing vaccinations is an issue that just was raised. And, you know, when will people in psychiatric hospitals be prioritized for getting the vaccine? And so we're looking at that also as some new questions that didn't make sense to ask back in the summer, but may now.
Yeah, the survey that Joe Parks presented at our last webinar in Maryland is being repeated, that I can tell you. Do either of the others of the two presenters know about any systematic data in the private behavioral health care system? Right, it sounds like no. So I'm glad at least we have information on the public behavioral health care system, which after all is where disproportionately people of color receive their care. So in terms of our immediate interest in that topic, that will be very helpful to us. There was a question that relates on different levels to each of the three of you. So I'd like each of you to respond to this. The observation was made that in order to intervene organizationally, those organizations needed to have buy-in, to be willing to shift from having the burden for resilience on the individual healthcare worker to taking some of that responsibility on organizationally. Dr. Wu explained to us a little bit how it happened at Johns Hopkins, but if you could enlighten us on where did the impetus really come from to take that organizational step. When I asked Ted to respond, you're in a federated system, so you're dependent on whatever each state does. So I'd be interested in how you as an organization dealt with that federated problem. And Arthur Evans, you're in a voluntary organization that's national. So I'm kind of interested, expanding on this questioner's inquiry, just if you can enlighten us on this, where the buy-in comes from, how do you make that switch from burden on the individual to an organizational responsibility? Anybody want to go first?
I'll start. I think that's why I was talking a little bit about the whole PPE, that phenomena that many people of color engage in, because I think most people are not even aware that that's something that's going on all the time. I think it comes down to what's the organizational mission? And if the organizational mission is to provide first-class healthcare to the people who walk through the doors of their organization, they can't do it if there are parts of the organization and parts of the workforce that are not optimally functioning. So rather than seeing this as doing something for a particular group, I think it's for leaders to understand that it's in their best interest to make sure that everyone is functioning at the highest level possible, number one. And then number two, that if they're going to do that, they have to recognize that there are these important differences between groups that if they're going to do that, they have to pay attention to and be willing to devote resources to address some of those issues. So that would be the way that I would think about it in terms of getting people to understand why this is so critical for leaders.
Great, thanks. Dr. Wu, do you have a sense of, how
Yeah, I would.
occurred at Hopkins?
Yeah, I think that Dr. Evans, we're buddies now. Dr. Evans' comment was very insightful. I think that it really, you have to have leadership behind it. And they have to understand that even if they're only thinking about their own self-interest, that if you want the organization to do its job, if you want it to function, that the individual players and in all of the positions need to be healthy and fit. And so at our place, we were fortunate actually that everyone from the very top and the commanders of the command center put well-being and resilience of the workforce as the #1 priority. Because if people were calling out, if people were depressed, you cannot hold them. Individual people are not responsible for their own burnout. That is really the leader's job.
Yeah, we have to stop first blaming the victim before we can get onto the organization.
Meditate more, be more mindful and stop crying. It's not, that's not the way to do it.
All right, we're all buddies online now, Al. So, Ted, do you want to reflect on it? I know you're on the research side, but I know it's a small enough organization. You may have some sense about any of the challenges raised by our federalist system for NASHPA.
You're on mute.
Helps if I unmute, but each of the states is its own sort of unique system. But I will point out that back in June, the board from the National Association of State Mental Health Program Directors and the National Council of Behavioral Health jointly issued a statement on repairing behavioral health care disparities and racism within the behavioral health system that lays out a set of steps in terms of opposing working to eliminate pre-existing social health care policies, laws, working on policies to promote equity for everybody and challenge disparities. The public system, as you said, does serve more of the minorities than the private sector does. That's where people with are economically disadvantaged go. And I'm always impressed by how much many of our state leaders are really trying to recognize that. In our survey, we kept hearing how they are concerned about their workforce, exactly as Dr. Evans and Dr. Wu were talking about. Dealing with people with severe mental illness in the midst of the pandemic has put an incredible set of stress and anxiety on the behavioral health workforce. And I think they're struggling, what's the best way to address it, especially if you have to have a hospital staff 24/7, but they are cognizant of it. And I think one of the areas, that we want to learn from and lean from our colleagues on is, how do we help address the mental health needs of our mental health workforce?
Great, thanks, Ted. I just have 2 or 3 minutes here before we end the webinar. And the final question for each of you to reflect on, it revolves around a theme that came up in several of the questions, and you hear it all the time. So we want to be able to explain higher rates of behavioral health problems, COVID, a lot of these phenomena associated with the pandemic, why the rates are higher in persons of color. And then you get the observation that, well, persons of color is a code word for a heterogeneous group. So if there are cultural differences that explain it, well, how do you remedy that? You have to tailor. Is there a risk that in tailoring and addressing the problems in one group, you're going to run into a cultural problem with another group? And this is not only an issue for the pandemic, but we're now facing vaccine hesitancy. And for a variety of reasons, understandable, there's more hesitancy in certain members of our population of persons of color. Do you have any reflections on how we should think about this?
Yeah, I'll jump in first. I think this is a really important question. We don't have time to go into all of the reasons why we see disparities, but a couple of things that I think people should be aware of. Number one is that disparities for communities of color play out differently in different communities. So you can't assume that in New York, that the disparities will look the same way in Wichita or Los Angeles for that matter. So it's really important to collect the data so that you know how the disparities are playing out, and you have a better understanding of why they play out differently in different in your particular community. Secondly, the issue of addressing those disparities when we see them, I think is critical. It goes back to the point I mentioned a while ago. When I was a mental health commissioner, my goal was for everyone in our system to achieve optimum mental health and optimum health generally. And what we know is that because of those variations in populations, the only way to get at that is to understand what's driving those differences, and then to work with the people from those communities to both understand and develop the solutions to them, and then to implement them in partnership. And I think when you do that on a broad scale, that's the way you raise all boats. It really does have to be an effort that's tailored for different communities, because in the absence of that, we absolutely know that using a generic approach across very different populations of people don't work. We have lots of data for that.
So the first step is being aware of that, and then being committed to do the right thing group by group.
Exactly, and having the data to inform what you're doing. You can't make an assumption.
Yeah, great, thanks. Elwood, do you have a comment you want to make?
Yeah, I mean, I think that some of this is about policy, changes at the policy level, but those policies have to be made understanding that if you're not careful, they could cause more problems than they solve. And so the policy have to accommodate the fact that individual people are individuals, and different channels and different solutions are needed to reach them and to help them. For many people of color, COVID is just the straw that breaks the camel's back. I recall talking to a nurse who was in tears. She was a Latinx woman, and there have been some stressful things. There'd been a unsuspected COVID patient on the unit, and she said it's not just that; it's that I've been moved, so now I'm working on the weekends, so now I need to get childcare because I'm not home on the weekends. My husband is out of work. My mother is sick, and we're having financial problems. And so COVID was the thing that caused her to call us, but it wasn't the problem.
Well, it's instructive to end on a particular note with a person's story. I want to thank all three of you for your presentations. We have to end the questions now. And I'm going to turn it back over to the co-chairs of this particular webinar series, Deidre Roach and Lark Huang. I'm not sure if Lark is still with us, but thanks to all three of you. Over to you guys.
Well, thank you, Howard. We'd like to express our sincere appreciation to all of our distinguished speakers, Mr. Ted Lutterman, Drs. Albert Wu and Arthur Evans, for their outstanding presentations, to the phenomenal staff at the National Academies, our forum co-chairs, Colleen Berry and Howard Goldman, the entire workshop planning committee, and to everyone who made this vitally important series of webinars possible. Most of all, I'd again like to thank our audience. As always, we sincerely hope that this series of webinars has given you both information and inspiration that will enrich the work you do day to day, every day, to make life better for people at risk and living with mental health and substance use disorders, and the heroic people who serve them. Take good care until we meet again this holiday season, and always, we wish you safety, vibrant health, joy, and most of all, peace.